by way of explanation, this is admittedly a bit of a, you know, in the weeds topic potentially for folks who are not seeing oncology patients. But I wanted to talk about it because this is a therapy that we've been offering in Hawaii for about 2 years now. Um, One of my counterparts in the CAP oncology group has been offering this. She's the director of cell therapy, Stephanie Lim, um, about 2 years now. And we've done about a dozen patients roughly at this point um, in pediatrics. So this therapy is something that is, complicated and not common yet, but it's becoming more common. And as I'll kind of explain, we're going to be having more and more of these folks out in the community. And I wanted to kind of give a background and explain this therapy because it is, kind of complex and kind of super interesting in my mind. But I'm also, in this space, so I find it interesting. But I think it'll be relevant and useful because, next time you see one of these folks, and you will eventually, I think there's enough of an indication for this that you will see them eventually. You kind of know what we're talking about when we're doing, and it'll be less hopefully crazy and oncology insane stuff, which again, admittedly, we do a lot of. So I'll introduce myself first. So I'm Tristan Knight. Um, I'm a pediatric oncologist, hematologist, and bone marrow transplant physician at Kapiolani. I was on the mainland for a good number of years after doing my residency in Hawaii originally, 2013 to 2016. Moved back about 6 months ago now. My wife's from here, and so our goal was to come back from the mainland. So yeah, I've been here about 6 months. I gave a presentation about a year or so ago about bone marrow transplant. At that point, I was still based in Seattle at Seattle Children's, but now I'm back. So, all right. So, by way of disclosure, go to the next slide. So, I have none. We're going to be using off-label medications, obviously, as most things are in pediatrics, and I have no relevant financial things. Learning objectives, can read through this if you want to, but basically we're going to talk through CAR T from start to finish, the basic mechanisms behind it, why it works, how you manufacture them, when we would use them, major complications, including things for after the process itself. Next slide, please. So by way of background, so cancer is fundamentally a failure of the immune system. Obviously, you have, cancer cells are, proliferate and grow and expand and such. But the first thing that happens is the immune system fails to find them. Just to make everyone super nervous, most of us have cancer in us at all times. But the vast majority of the time, your immune system finds it, deletes it, and gets rid of it, right? That's why we have so many mechanisms that are, checkpoints in our cells, and our immune systems are so good at doing things. Because, obviously DNA proliferation is prone to errors, and so our bodies are good at deleting that and preventing that from happening. The issue arises when the immune system fails to do that. So that's why you have in people who have immune deficiency syndromes, you have more cancers because their immune systems are less good at finding those things, as a for instance. Or if they're exposed to like radiation, there are more cells that have mutations, so more of a chance of them breaking through and causing actual malignancy that comes to clinical attention. So the immune system basically, fails in cancer, and that's kind of how it starts. Next slide. So some very clever people, from a long time ago, realized that maybe you could use the immune system and kind of reactivate it and make it go after the cancer cells. So this is back in 1891. This guy, William Cooley, did what sounds terrifying in a pre-antibiotic era. I mean, keep in mind, we did not have antibiotics until like, the 30s or 40s. And so he was taking strep and he was giving people literally bacterial infections. And sometimes it didn't kill the patient, and sometimes it actually cured the patient. And so that kind of led to this idea that if you reactivate the immune system, you can kind of tell it that the cancer is there, that it needs to attack it. So that was kind of the first idea of this. The article is there from 1908, the idea of germs as treatment. And that's kind of the origins of cellular therapy in this space. Next slide, please. So the other main therapy we do, and I mentioned this, I talked about this about a year ago or so when I first met with this group, is bone marrow transplant, right? So bone marrow transplant, just to give the 2-second version, we take a donor's immune system, we implant it into a patient with, in this case, cancer, after first getting rid of the recipient's entire immune system and deleting it with chemotherapy. And so when this was first being done in the 70s, 80s, really is when it kind of came into its own. The thought was that the reason this was actually effective was because you could use higher doses of chemotherapy to treat patients. Because the main dose-limiting toxicity for most treatments for cancer is, suppression. Basically, your blood counts are super low. And if you give high enough dose, you ablate the marrow, you wipe the marrow clean. So the thought was that that was why you're curing patients. To make a long story short, that involved several Nobel Prizes. Um, what they figured out was that actually what's curing patients in bone marrow transplant is not the chemotherapy. It's actually what's called the graft versus leukemia or GVL effect on the left there, where basically what you have happening is the donor's immune system is seeing a foreign cell, quote unquote, um, and recognizing it and attacking it. And those cells are leukemia cells. And so what you actually have happening is not the chemotherapy curing the patient, but in transplant, you have this GVL effect attacking and getting rid of cancer cells. Now, the flip side of that is graft versus host disease, which is literally the same process, where you have the donor's immune system attacking not the cancer cells, but the normal host tissue. And that's the main complication of bone marrow transplant. And so what we try and do in transplant is maximize graft versus leukemia while minimizing graft versus host disease. And as you can see, I mean, the problem is that it's literally the same process. And so there's a lot of work going into that has gone into is going to continue to go into how you have one without the other because they're two sides of the same coin. It's the same process really. So there's some very cool things that are happening in that space to try and have one without the other. So next slide, please. What if we could have graft versus leukemia without having graft versus host disease? Basically, having all the benefits of immune systems that attack cancer cells but don't attack the host. And you might ask, well, we have that. Some ways we have autologous bone marrow transplant where you take the donor system, immune system, um, preserve it, give chemotherapy, and then give it back to the same patient. The issue there, though, is that those cells are the exact same cells that were already there. They don't recognize the cancer, so you aren't doing anything by turning them on and off. Um, in autologous transplants for cancer, which we do, um, they're kind of unique cancers where the actual point of those kind of transplants is actually the high dose chemotherapy. Um, so you're destroying the immune system for later purposes. But in things like leukemia, where the cancer is a cancer of the blood and marrow, um, the only kind of transplant you can do to cure them is an allogeneic transplant, so a different donor into the recipient, because it sets up this graft versus leukemia effect. But what if you could have the GVL, graft versus leukemia, with no GVHD? Next slide, please. Well, we can do that. And that's kind of the whole point of this CAR T stuff. So going briefly through the immunology stuff, which most of us have all forgotten, and I have to remind myself this usually too. So this is metaphysis. You can see coming down there, we have hematopoietic stem cells. You divide into lymphoid cells, myeloid cells, lymphoid cells has T and B lymphocytes. And so what we're talking about in this case is the T lymphocytes. Next slide, please. So T lymphocytes are so called because they start in the bone marrow. They go to the thymus, right? T is thymus. So thymus lymphocytes. And they go into the thymus, and there they undergo multiple, multiple aspects or multiple processes that basically cause positive and negative selection, where basically you have positive selection in that they have to respond to the immune system or to the cells that are there. And if they don't, they die off. And the negative selection, where the cells that react too strongly with the body also die off, thereby preventing autoimmune conditions. So you have to have this kind of positive, negative immune selection happening. Next slide, please. Then, once we have fully functional T cells, we can kind of go top left down and then right down. You have these T cells in the thymus with T cell receptors. And then to kind of remind everyone here, right, the CD8 cells will bind to MHC class 1, CD4 cells to MHC class 2, and essentially use their interaction with the MHC to either not kill or to kill cells, depending on what they find. So that's how T cells work, right? You have this maturational process, this development of very specific antigens and targeting, and T cells are very specific, right? They're primed to recognize certain antigens only, and so they're very specific. So that's basically a normal T cell process. Next slide, please. So T cell CAR Ts then. So what does that mean? So basically with the T cell, what we're doing is we're taking um, a T cell, we're modifying it genetically to express this chimeric antigen receptor. So CAR is that chimeric antigen receptor that specifically targets, recognizes, and eliminates a targeted antigen. And that's the part, the antigen we're targeting, that we can change and adjust and do different things with. And that determines what we can actually target with these cells. Next slide. So just to remind everyone briefly, so what a CAR actually is you're creating an artificial T cell receptor, right? It's not a normal one to like, I don't know, virus, chickenpox, herpes, whatever. It's a T cell receptor that's been built in a lab to target something it wouldn't normally target. In this case, often B cells of some variety, which we'll come back to. So what these actually involve are a few different parts. There's outside the cell on top there, you have an antigen binding domain that recognizes whatever you're trying to target. You have a costimulatory domain kind of inside the cell and an activation domain inside the cell as well. And so that's basically the structure that we build into these cells. Next slide. So this is a little bit crunchy. I'm not going to stick on this too long, but basically, the process of growing and developing CAR T cells started with trying to do this very simply, where basically we literally took, say, CD19 on B cells, right? Take CD19, upload it into the cells, which I'll explain how that works, and release it into the body. Great. Works for a few weeks. But these first generation CAR T cells did not survive very long, and they would, die off eventually. And it was figured out that what you need to have is what's called a co-stimulatory domain. So you get to the second generation there, where basically, in order to have these cells grow and live and develop in the body, you need to give them a stimulatory domain so that when they're activated, they grow and divide and expand, right? So with these second generation CAR T cells, you get this super cool thing happening where you're literally having a living drug. You are giving cells that will grow and divide in the body and persist and keep growing and dividing forever, theoretically speaking. So that requires there to be these costimulatory domains for these cells to um, to be there. The third generation ones are kind of experimental in this case, but basically they are trying to expand if one domain is good, two is better. Um, and the commercial products we have available, which I'll come back to, are all second generation products at this point. But that's kind of what I wanted to mention about this slide is that, these T cells, the whole point is that we give them once and they ideally last forever. All right, next slide. So what can we target? This is complex, don't memorize this, but there are lots of options we can target. Basically, the limit is our imagination, really. Anything you can have an antibody to, you can theoretically build a CAR T cell to, because the process itself is relatively straightforward. Where basically you are just uploading the target into the T cell and telling it what to attack. So CD19, if you might remember, CD22, CD20, these are B cell malignancy markers. But you can build them to AML, you can build them to Hodgkin's, you can build them to anything you really want to. But B cells, next slide, are the most easily targetable. And so there are actually, this is a slightly out of date slide, there are actually 6 FDA-approved therapies right now that target some version of B cells. So the first 4 there, the CD19 targeting ones, are commercially available, FDA approved, and they target various B cell malignancies because they all target CD19. Now, why CD19? Because to be honest, we don't need it. There are very few things that your body has CD19 on apart from, well, it doesn't have anything on apart from B cells. So getting rid of B cells is not actually a huge problem, which is good in many ways because the commonest malignancy in children is B cell ALL, B cell derived leukemia. So by targeting that, you actually don't cause many issues. Similarly, down at the bottom there, BCMA, B cell maturation antigen, is the primary marker expressed in multiple myeloma. And so multiple myeloma is a malignancy of the plasma cells as adults, and it's case reportable in kids. It doesn't happen in kids, but in adults it's pretty common. And so when we are giving CAR T cells for multiple myeloma, oh well, you lose your plasma cells. The end result here basically is that you need to give someone IVIG and don't really have much in way of immunoglobulin being produced. We'll come back to that point. But it's pretty okay to do that. The issue then is that in other kinds of cancers, AML, for instance, right? Why can't we use it in AML? Well, we can, we do. The problem is that AML, the markers expressed on myeloid cells, are much more specific. And if you delete those, you end up deleting all kinds of other cells you actually need. So, for instance, stem cells, kind of need those. Um, and that's basically why the field is specific to B-ALL and multiple myeloma right now. A lot of experimental things happening with other kinds of malignancy, but your key limitation here is finding a target that you can attack and destroy without causing other issues. Next slide. So this is what I was suggesting here earlier. So CD19 is just B cell. You can see the growth there along the bottom. It's not present on stem cells, which is important, but it's present all through this maturational process. So where you have B cell lymphomas, leukemias, which are the commonest ones and the commonest kind of cancers in kids. Um, so you can use these cells there, but it's not expressed anywhere else. And that's important. CD22 to CD20 as well, also pretty specific. But CD19 is, we know it works, so we use that from that standpoint. We could also use this in CLL, which again is not a pediatric disease, but it can be used, and actually originally was used there for the first time. That was the original indication. Next slide. All right, so why CAR T? And I think there's a chat question in the chat. We can address that on it now or after, or?
You absolutely can whenever you want.
Okay.
Anytime that it works in your flow.
Yes, excellent. So the question is, how do you prevent the CAR T cell from developing into cancer itself? That is an excellent question. And um, that is kind of a problem, actually, because it can. It's not often, and it's not really a thing, but one of the side effects that we can see extremely rarely is what's called insertional mutagenesis, where basically the CAR T cell itself becomes cancerous. Again, it's not common, and I'll talk about the techniques for this. But one of the reasons we do long-term surveillance for these is because we want to avoid that happening. And to make a long story short, it doesn't really happen. It's not a thing we really have an issue with in this technique. But it can be seen in some gene therapies that use this as well. So it's a good question and it's a valid concern, but for reasons that I won't go into because they're super crunchy, doesn't really cause much of an issue in CAR T cells. So great question though. That's one reason the FDA was leery of these things when they were first released, because that was the key concern was, are you just going to cause cancer somewhere else or cancer that you've now created? So yeah, good question. Okay, so why CAR T cells? So as I kind of mentioned, you basically have the ability to produce cells that are not going to react and cause graft versus host disease in a patient. These are your own cells, right? They take, and I'll explain the process here shortly. They're not reliant on HLA antigens. They're universal and they can target anything you want to target. You have lots of options to target them. You can produce them pretty rapidly. I'll go through the timeline. There's functionally no risk of autoimmunity or graft versus host disease. I mean, there's some minor risks. You are manipulating the T cells and giving them different options to do things. But basically, your risk is negligible. And as I said, single drug, living infusion, you give it once and theoretically you're done. That's kind of attractive, honestly. Next slide. All right, so let's walk through this. I'll give a quick overview and then I'll go through the steps individually. So the first thing we do, blood from the patient is taken to the lab. We generate CAR T cells there. We take those cells, we freeze them down, ship them back, infuse them into the patient, and they do their work and get rid of the cancer. Next slide. going into a little more depth. So for the kids we're doing this with, we do need central lines, and this is something that, most of our kids would have anyways, but there are specific lines we would need to do apheresis collections because the collections themselves are kind of involved and use apheresis machines, which I'll explain in a second. But patients will need specific central lines, even if they already have a central line, because the usual ones we place in folks with ALL do not handle the pressures and the flow rates that we need to harvest the cells. So that is something to just bear in mind that your patient may end up with a different kind of central line for the process of CAR T cell collection. Next slide. So how do we collect them? So this is an apheresis machine. It's functionally a big centrifuge. Basically, you take the patient's blood out from one arm, or if you are using a central line, which is usually the case, one lumen comes out, one lumen goes in. There's a big part that spins, it's a centrifuge. And based on where you put the straw functionally that collects the cells, you can choose different things. You can choose red cells if you want to, platelets, white cells, which we're interested in this case, plasma, whatever. So it's the same machine that we would use for collection of stem cells, of removal of red cells, removal of antibodies, same machine, different options. So that's what we do. This takes a few hours, and we make sure we get enough T cells, which is what we're specifically interested in. Next slide. This is kind of the cool part, and I guess the intense part. So the first thing that happens is that to create the T cells, they've constructed a CAR T construct, it's called, where basically this is the blueprint for what you're trying to target. And basically, the way this works is you have the antibody that you're trying to generate that targets the antigen. And through very involved kind of cool processes that are all patented and all that, you create the genetic blueprint for this. Then what you do is really cool. You take that gene and you insert it into a retrovirus. Remember, the way these viruses work, right? They take their material inside them and they upload it into, the host genome. And so that's literally what we're doing here. We're taking the genetically created CAR construct and we're uploading it into the DNA using a retrovirus. Um, then what you do is you produce these cells, you take the T cells and you expand them and grow them with various factors that produce T cell growth. That's basically, cytokines and such that expand T cells. And you grow and divide these things. So basically, starting from a pretty small amount of T cells, you basically can produce, millions and millions and billions and millions of T cells. Then what they do is take the cells and freeze them. Um, and ship them back to us. And we have our cell therapy lab here that handles this process. They're very, very good at that. And they store them for us until we need them. Next slide. The bridging chemotherapy part. So you might be asking, well, we took patient cells. How long does this all take? The manufacturing process, 4 weeks is about right. It's super variable and depends on shipping times. And obviously there are bottlenecks in the manufacturing process. This is kind of a technical process, so 4 weeks is about right. But if you have someone with aggressive leukemia, and you kind of need to do something for them. So what we'll do is various kinds of bridging chemotherapy, and that can be very variable. And so we don't just kind of let these patients go off into the wild. They're actually specifically in getting chemotherapy, and the point is to try and kind of hold things steady, but not give them too much. Next slide, please. Then we do what's called lymphodepletion. So this is a couple days of chemotherapy. It's not really cancer chemotherapy in the sense that the goal here is not to treat their cancer, although it, will have some activity, but that's not the point. The point is basically to clear out lymphocytes because when you give the lymphocytes back, T cells back, you want them to grow and divide and expand. And if there's a ton of lymphocytes already there, they're going to soak up the factors that are going to help expand lymphocytes, and so you don't get as good a response. So this is actually studied, early on to figure out ways to optimize CAR T cell efficacy, and giving lymphodepleting chemotherapy is important. So the patients will get this kind of chemotherapy a few days before the T cell infusion. Next. This is what it looks like. There are different vials forms that it comes in. It's honestly very anticlimactic. People think they're going to get something very cool that looks, super intense or some kind of procedure. Almost everyone I've ever given this to is like, that's it. or some variation of that because I mean it looks, it's you know couple dozen cc's of functionally, frozen and thawed cells. Um, Takes a few minutes, really. It's pretty uneventful, ideally. Um, but yeah, it's pretty anticlimactic for most people. But probably the most expensive thing that you'll ever hold if you do that, because this process costs hundreds of thousands of dollars depending on the manufacturing process. So it's a rather expensive thing to be, to have. Um, Post-infusion, next slide, please. Um, This is kind of the overall structure. So this is basically how it works. We get the workup, leukapheresis, lymphodepleting chemotherapy, about 3 days. The infusion happens on day 0, which is from transplant literature, how that works. We monitor for side effects. And depending on how one does this, you can do these infusions inpatient or outpatient. Um, it depends a lot on availability of caregivers and local ability to stay locally, but and also side effects that are present or not. There's a trend, especially in adults, to doing this outpatient and just monitoring closely, but you need to be within, a few minutes of the hospital. We'll talk about side effects in a second, and that's why. Usually we keep folks close by for about a month after, because that's when most of the complications are going to happen, and then they're free to go home after that. Next slide. So, why do we actually care about doing this? And what are the indications for like choosing this therapy? So, this is a young woman named Emily Whitehead. This is the first surviving CAR T patient. She had ALL. She was treated at Children's Hospital of Philadelphia, and she was one of 2 patients who originally received this therapy. She survived. The other patient died. She she and her family, they have the Emily Whitehead Foundation, and they've been advocates for access to this therapy. They've been super engaged in this therapy, and they've been really wonderful advocates for CAR T cell, and they're really spokespeople for this procedure. Um, in her case, she was multiply relapsed, and basically this was the only therapy that was left to her to salvage her. Next slide. So the reason we do this is basically because, to summarize, um, it's a therapy that can salvage the unsalvageable. Um, so the commonest indication for this is relapsed or refractory disease. Sometimes we'll choose to do this therapy instead of bone marrow transplant for a few reasons I'll get into. But in broad strokes, this is a therapy we'll use for people who have had relapses. Now, this is the landmark study that kind of first led to uh, this is the NEJM paper that basically led to like this therapy becoming um, well known, I guess, from 2018. So these patients, OS is overall survival, EF is event-free survival, so basically survival without cancer in this case. So what you can see is that getting out, to a year post-infusion, somewhere around more than half of people are alive and leukemia-free. These patients are people who have mostly had bone marrow transplants, in some cases more than one, multiple lines of therapy, usually at least 3 or 4. Um, to put it lightly, put it bluntly, these are basically patients who would be dead. So this is a therapy that can be used to salvage really people who are unsalvageable. Now, at this point, what's happened is it's moved more front line, so we don't always wait until it's the last possible thing we can do. We can, but we don't usually do that. But I've shown this slide as basically a way of saying that this therapy honestly is, has been and was and has been revolutionary. I mean, to get this kind of response in what are functionally refractory to everything patients is pretty incredible. Again, this is the short-term-ish data, but it does kind of show the point here of using this. So next slide. So this is kind of the clinical trials that basically have led to the therapy. And so I'm not going to go through all of these studies, but these are adults and pediatrics. And you can get a sense there that most of these patients have already had bone marrow transplant at some point, and the vast majority of them achieved response. Again, this is basically people who otherwise would have been dead pretty quickly because these are aggressive leukemias, and when they're refractory to treatment, they don't really respond to much. Um, but you can see that there's, in many cases, well over 50% survival So this is a very effective therapy that is useful for these group of folks. Next slide. This one I want to put up because this is the longer term data. So, I mean, this is certainly an effective therapy, but it is not a panacea. It does not cure everything. Um, and what seems to make the biggest difference is basically the disease burden in the marrow, which we refer to basically saying that, if you look in the bone marrow, how many cells are actually there? Um, and the long-term data seems to show that the more cells you have, the less effective the therapy is, which is in keeping with most of our therapies in oncology, honestly, where basically you want to use a multi-pronged approach to reduce the amount of leukemia cells in the bone marrow, and the more able you are to do that, the better the response. Because again, these cells are spectacular and wonderful, and they work very well, but they're not going to be able to fix someone's marrow that has not always going to be able to fix someone's marrow that has, tons of blasts. Isn't always the case. We certainly do see responses. Um, but I want to put this up here just to basically show, that this is, like anything. Um, it does not cure everyone, but it does offer us an option to cure people who otherwise would not be able to receive cures. Next slide. There are different ways that cancers can still escape. So maybe asking like, how can a cancer possibly, avoid this and get around this? Cancers are very smart, unfortunately. So that first slide on the left there, you have activation of the CAR, and it's targeting CD19, which is the little hexagonal things on the cell surface. What can happen? A few different things can happen. The cells, you know, are very smart. They can basically turn off CD19. It's not obviously a conscious process, but basically it's selective pressure, right? It's the same thing that causes antibiotic resistance, but in cancer cells. You're targeting a CD19 on the surface. Cancer cells that have some mutation that makes it express less, express not at all. They're more resistant. They grow and they, they're basically successful. So it's basically the same process. And I mean, cancer cells, by definition, are mutating all the time. So this works, but that's generally the usual mechanism we see where there's antigen escape or downregulation. Or sometimes they can just change to a different kind of cancer completely, switching over from ALL to AML, for instance. In any case, what happens is you aren't expressing CD19, and so it doesn't matter how much CD19 directed CAR Ts you have, they still can escape. So it's, again, not a perfect therapy. It's a very good therapy, but it's not perfect. Next slide. And this is basically showing that exact same thing, that other people who relapse, again, these are heavily treated patients with CD19 CARs, heavily pretreated. Somewhere around a third of them roughly relapse. And of the ones who relapsed, the vast majority of them are CD19 negative relapses, which basically is kind of like saying, a bird without wings, or in oncology space, it's something that shouldn't exist. Like, you shouldn't have CD19 negative B cell. It's kind of a contradiction in terms. Um, but in this case, because the T cells are doing a good job of getting rid of CD19, you can still have relapses from that standpoint. I'll also kind of mention there and pause briefly to say that the timeline we do these therapies on, there's a few different time points. And one time point we'll use is people who we cannot get into remission at all. So they're treated for a month, second month, and there's no remission. They still have active disease. But that's an indication that they're refractory to therapy. These patients always used to go to bone marrow transplant. At this point, though, we'll often send these patients for CAR T cell therapy first to try and get remission and treatment that way. That's the one first context, basically refractory patients who cannot get remission. The other context is people who have relapsed after treatment's finished or during treatment. Um, we'll do CAR T cell therapy when that happens. It used to be, and this is true for most oncology things, where the most effective therapies are kind of started off on people who are relapsed refractory, like super sick. And if it's effective, it's moved more and more and more front line until we get to a point where it's kind of makes sense to have it. CAR T cell therapy is one of those where it used to be used only in refractory, like most complicated patients possible, and it's still used there. But it's moving more front line now, where basically it's something that we'll do for patients before bone marrow transplant often, because it's a much less toxic, much less complicated thing than bone marrow transplant. Because, as I said, there's no graft-versus leukemia effect. It's your own cells. So there's no graft-versus host disease effect. It's your own cells. It's less chemotherapy, it's less side effects. So it's something that we often will do before bone marrow transplant and have bone marrow transplant available as an option if it fails, which is not as often, but does still happen. Um, to mention multiple myeloma, in that space, actually, it's become the frontline therapy for patients where basically they've stopped doing autologous bone marrow transplants for multiple myeloma almost completely now and have moved over to CAR T cells where it's gone from like, last line to basically first line therapy after chemotherapy. So that's kind of generally what happens. I don't expect to see that happening completely in childhood ALL because I think that, as we've shown, we still need to have some control of the disease first to have better efficacy. But, I can easily imagine a space in which we use a lot of these cells to these CAR T cells, you know, relatively front line. And I'm sure that I don't know if it's for a fact, but I'm sure there's a trial someone's doing, going to be doing or developing to do this as a first line therapy. It hasn't gotten there yet, but I'm sure that's coming in the next few years. I'd be shocked if it wasn't. Next slide. Okay, so now we should talk briefly about the side effects. This is the last couple slides here. So this makes complete sense when you think about it. So the main side effect of CAR T cells is called cytokine release syndrome, which is exactly what it sounds like. You have cytokines being released, and you have a syndrome that arises from that. Where basically the T cells are doing what they should do and causing all kinds of septic pictures. This looks like sepsis. It is fundamentally indistinguishable from sepsis unless you know what you're looking for, because it is functionally sepsis. It is an immune response. It's not an immune response to bacteria or something. It's an immune response to cancer. So looks like that. So this is generally speaking fevers, hypotension as you get more severe, hypoxia, tachycardia, all these things can happen. Basically imagine sepsis and you are imagining CRS. There are specific markers we can use to track and make sure that it's actually related to that. Um, and there are specific approaches we can use, which I'll come back to. But CRS is the main side effect. Next slide, please. This can happen roughly in the 2 to 29 days after the infusion. Usual is 1 to 2 weeks. This is why we keep people around. One of two reasons we keep people around, because this side effect is in most cases, the majority of cases, not a huge problem. We have them in the hospital, we have them on fluids, Tylenol, not a big deal. In a minority of cases, it's severe and they end up in the ICU on pressors. But there's really no way to predict who's going to have this. There's some relationship between the amount of disease in the marrow and the development of this, but you can have this effect happen with no disease, all the disease. You can have someone who has tons of disease and has no CRS. Doesn't mean it didn't work, but there's really no good way of predicting this. The other side effect is neurological toxicities, and that overlaps a little bit. Generally speaking, tends to happen around the first couple weeks, but can happen, as late as 6 months after the CAR T cells. Next slide. This is called ICANS. This is one thing that you actually may see more likely because by this point, they could develop this. This is actually folks who are usually back in the community and not as close to the hospital. So ICANS is extremely non-specific, which is super helpful, I know. Basically, it's neurological side effects. It is not well understood. It's thought that it may result from CAR T cells crossing the blood-brain barrier and cytokines being involved and produced there, as the cells potentially get rid of leukemia cells in the CSF, but it is not well understood why this happens. And it really can be anything. In the hospital, we monitor for this by having folks do, if they're old enough, doing cognitive function testing. In younger patients, we can often do things like just making sure that they're able to talk and laugh and sing and do pediatric things. But in older people, we'll have them write their name because the writing actually is probably one of the most sensitive ways to find this. Like if the writing gets really messy, that's default. But their writing visibly changes as this starts to happen. Altered mental status, aphasia, the severe version is seizures and edema. It can be fatal, again, rarely. But basically, if you have a patient who's gotten CAR T cells and you're seeing really any kind of neurological features, it's definitely worth chatting with us about because it could be ICANS. We would certainly admit those patients and watch them closely. Again, most of the time, these are patients we're not going to have, just, we're going to have them close to the hospital anyways. But this is something that you could see in patients who've gotten CAR T cells well after we have treated them, out to 6 months sometimes. Um, Next slide. So what do we do? Both of these can be treated fairly effectively. CRS, usually we do supportive care, Tylenol fluids, whatever. Tocilizumab is actually a rheumatology drug. It is an IL-6 inhibitor. So remember I mentioned that kiddo, Emily Whitehead, she got the first CAR T cells in pediatrics, and she got super sick. She was in the ICU. They thought she was going to die. And that would have probably honestly ended CAR T cells because this was the fear, right? They knew that these cells could be toxic because they produce a lot of cytokines, and that's the point. They cause immune response. And so um, they checked her cytokine levels and they realized that IL-6 was extremely elevated. And they had a drug, tocilizumab, that is, again, usually rheumatology in nature, that very effectively treats CRS by reducing the amount of IL-6 present and rapidly improves things. So we have a good drug that does that. If that fails, steroids or different kinds of steroids. The basic point here is to turn down or turn off the CAR T cells. Now we know after many years of doing this that this does not impact the efficacy of the CAR T cells. They still are usually around after tocilizumab is done. Um, it just turns them down. Steroids, a little bit more effective as far as like getting rid of CAR T cells, which again, you don't always want to do per se, but if the patient's, in the ICU in extremis and you can't fix them because they're super refractory, you don't have a choice always. And it's better to save the patient than the CAR T cells. So basically, you're sacrificing the CAR T cells for the patient in this case, giving steroids. This is why we say, patients who are getting CAR T cells, do not give them steroids under any circumstance, apart from life-saving things. Patients getting asthma treatment, totally okay. Maintenance, inhalers, not a problem at all. This is more like even doses like physiologic hydrocortisone, patients who have adrenal insufficiency or that kind of thing, or even stress dose steroids, not a huge deal. This is more like the croup or asthma exacerbation steroids that are an issue. Again, it always comes down to if the patient's going to die without the steroids, give the steroids. But this is one of those things that any oncologist who's treating CAR T cell patients would appreciate a phone call about because it's not a straightforward thing, and you shouldn't be up to you shouldn't have to make that call. So we're always happy to talk about this kind of thing if the situation happens. Fortunately, not super common to have this, but theoretically it could be a situation. ICANS, same thing, seizure prophylaxis and steroids, basically what it comes down to. Steroids get rid of lymphocytes and turn lymphocytes down, and that's kind of the whole goal here. So again, obviously we'll be around and talking to you guys at that point. Next slide. This is the last slide. So this is basically just a kind of a timeline of when we would expect side effects to happen. So the main long-term side effects after CRS and ICANS are done, again, this gets rid of B cells. We're talking mostly about B-ALL here. So B cells, as you all know, make antibodies and make, your ability to respond to vaccines and immune responses. From antibody standpoint. And so if you're getting rid of them, you're not going to have an immune response. Eventually, patients may have reconstitution of their B cells and plasma cells. Ideally, we want to see that happen at 6 months or later because we know if they have B cell aplasia, lack of B cells for at least 6 months, those people have better cure rates. But in some people, like Emily Whitehead had mentioned, like they can still detect her original CAR T cells that she was given, and she still doesn't have B cells, which, is it overkill? Probably. But it's been very effective as far as keeping her in remission. And so that's, it's kind of one of those things where it's a small sacrifice such as it is to maintain immunity. And then, we can give IVIG, obviously. We can give passive immunoglobulin if we need to. Um, but these patients will, in an ideal world, have persistence of CAR T cells, absence of B cells for, months to years. And so they'll need IVIG infusions. And revaccination is not, there's no point because they don't have B cells. They can also have impaired, production of especially platelets, long-term hematologic toxicity, long-term anemias, thrombocytopenias. That can last for months to years in some cases. Not a common side effect, but hematological toxicities can certainly be seen in the long term. If it's severe, we manage it with transfusions. Again, not a well understood toxicity. It's thought that that may arise due to cytokines from ongoing active disease in the bone marrow. And so that's actually a good sign that they're working still because there's still, you know, blasts, leukemia cells in the marrow that are still causing the T cells to respond and having production of cytokines that are suppressing hematopoiesis. So, yeah. Okay, so with that, we can move on to our slides. Next slide. So this is question one. There are four questions. So the first one, I'll give you a few minutes to think about this. So basically, who do we harvest CAR T cells from? Is it an unrelated donor? Is it the patient? A related donor like a sibling or a parent? Or are they generated on their own with no donor?
Summer or right, perfect. I was just about to
Oh,
say if we could pull up the poll,
fancy.
yay, thank you, even better. And then that gives us some time to just go through all the questions, and then we'll have you, Tristan, go over answers with us
Oh, cool. Okay, perfect.
once everyone has had a chance to add their input. I don't know if you can see the
Yeah, I
poll.
can see it there. That's cool. Okay,
I'm
great.
watching it in real time.
Awesome. Okay, so second
Wait,
question. I won't change the slides, but
yeah, and because everyone can kind of see the questions and just scroll
yes,
down.
perfect. So second question. What is not an indication for CAR T cell therapy? Ooh, yes, thank you. So is it B-ALL? Is it AML? Is it a B-cell lymphoma? Or is it multiple myeloma? What is not an indication for CAR T cell therapy right now? Third one. Um, what kind of CAR T cell, what kind of therapy are CAR T cells? This is a little bit of a tricky one because it can sort of fall under many of these. So this one's maybe a little bit unfair, honestly.
You're
But
keeping us on our toes at lunchtime. It's a good thing.
I try. And the last one is what is not a major side effect of CAR T cell therapy? Is it neurological side effects, sepsis-like illness, or prolonged cytopenias? And I'll defer to you guys as far as when you guys want to close the poll.
Um, how common do you think this is going to be as something that we'll kind of encounter in our patients?
Yeah. It's a good question, and the answer is more. Um,
Hmm.
so, as I said, I think about somewhere over a dozen folks have gotten this over the last few years. Again, it's not common, right? But um, as this becomes more common, I mean, something like, and I think, Lori, are you on? I think I saw you come in. Um, I think there are around about 60-ish new diagnoses of cancer in Hawaii per year, of whom probably around about 20-ish are going to be 20 to 30 are going to be BALL. So of that group, if every patient who were to relapse were to get this therapy, that would probably be around, you know, 3 to 5 of these at some point giving. So again, this is never going to be, fortunately, a common therapy. Um, but if you draw that out over the next few decades, it's going to become more common. And the data I've just shown you is specific to BALL, but this therapy is coming for multiple kinds of cancers. Um, I mentioned, we don't do this too commonly in lymphomas in kids, but lymphoma is an FDA-approved indication. Um, they're working on it for every other kind of solid tumor that exists, basically. And so this is specific to BALL, again, the data, but the side effects, the general concepts, are common to CAR T cell therapies in general. So I can't give numbers besides to say that it's going to become more common. Um, but it's going to depend on how fast they can roll out the other indications. Solid tumors, especially, are kind of complicated. They're working on a lot of trials in Seattle, where I came from, for brain tumors that are showing incredible responses. They've been able to cure literally incurable cancers, DIPGs, using CAR T cell therapy. Nick Vitanza up there is doing some spectacular work with that. Um, Also, just a really generally pretty awesome guy. But yeah, so there's these trials that are becoming more common, and especially for the serious incurable cancers, we certainly are. making progress there.
So cool. I love nerding out with you.
I do it by default, so
Exactly. No,
yeah.
this is so interesting. I think to be mindful of time because we only have 2 more minutes. Shall we quickly go over any poll question results where the answer was divided? Maybe question two, that
Let's
was pretty divided.
Yeah.
And actually two, three, and four, if you could give us the answers to those.
Yes. So I'll just resume all of them. So yeah, question
Sure.
one. Yeah, so all of this. Yeah, so good job. So, yeah, good job. So this is the patient. These are derived from the patient. There are experimental studies working on doing what are called universal CAR T cell therapies, where they have off the shelf, which would be great because it would reduce the time. You wouldn't need to manufacture them from a patient, so it would reduce the time from 4 to 6 weeks to 0 weeks. Because you just would have them on hand and just give them. But there's a lot of issues with that because, as you can imagine, right, the whole point is they're immunologically active cells, and they may recognize the host as being a foreign thing and attacking it, which is not ideal. Not an indication. So as AML right now. So the FDA approved indications. We have B-ALL. We have multiple kinds of B-cell lymphomas, and multiple myeloma is used for CAR T-cell therapies, but obviously not in children. But AML, there's no non-experimental CAR T cells for AML. Three, yeah, that was kind of my fault. I should have focused on this more. So this technically is a cellular therapy. The difference here is semantics, and again, this is my fault. So in cancer land, immunotherapies we think of are ones that are using the immune system unmodified. So we have agents that basically are bispecific antibodies, for instance, where basically one end of the antibody, I think the Y shape, one end will target CD3 and bind CD3 to CD19. So you're literally bringing a T cell and a B cell together, but not modifying them. It's a facto. So this is a cellular therapy because it's using cells directly. But again, I should have focused on that. So my bad. Um, Question four, yes, exactly. So you can have neurological side effects. That's one of the side effects there. The sepsis illness, yes, cytopenia is for sure. Rash is not commonly seen. So if you have a patient who got a CAR T cell and then 6 months later has some kind of rash, we're always happy to talk, but I wouldn't expect that to be related to the CAR T cells themselves. And then if you go to the last few slides, there are my citations, and then there is my email and my cell phone. And always happy to chat about these kids. But yeah, you guys want, we can definitely go through questions or look at open their mics. I can see if there's any in the chats here. Yep,
So
any
far, thank
questions?
yous coming in all around. I do also want to be mindful of time. If anyone has maybe one
Oh,
question,
I
we could
finished right
probably
at
squeeze
3:30. Good
in,
job,
but
1:30.
you
Good job,
finished
me.
right on time,
Good job, me.
exactly. So, um, if anyone does have any questions, you have Dr. Knight's contact info. He is a great consultant. I talk to him every day this past week for my patients. And thank you so, so much again. I really appreciated you joining us for a second presentation this year. For everyone who came and listened and participated, thank you so much as well. Our next slot is going to be on August 6th. It's going to be our pediatric cardiologist, Dr. Kristen Fujita. She will be talking about Kawasaki disease from a cardiologist perspective.